Welcome back to More Than a Therapy Couch, the podcast where we go beyond the walls of traditional therapy sessions. I'm your host, Tiana. In a world that's constantly changing, so is the way we navigate our mental and emotional health. We're here to embrace the notion that healing and growth extend far beyond the walls of a therapy room. Today's episode is all about understanding OCD, what it really looks like and how it's diagnosed, and most importantly, how to break down the stigma that surrounds it. I'm thrilled to be joined by Alyssa Cohen, licensed clinical social worker, an experienced clinician who often works with clients with OCD and anxiety disorders. She will help us separate fact from fiction and share practical advice for anyone navigating life with OCD or supporting someone who is. So grab your emotional support water bottle, find a comfy spot, and join us as we embark on this journey. Unfiltered, no judgments, just you, me, and a couch. As a reminder, the topics discussed are for educational purposes only and are not meant to be taken as clinical advice. If you are concerned about you or a loved one's mental health, consult a mental health professional or call SAMHSA's 24-hour hotline at 1-800-662-HELP. Hi, Alyssa. Thank you so much for coming on today's episode. Can you tell us a little bit about your journey getting into the mental health field?
My pleasure. Absolutely. So I studied psychology for my undergraduate degree simply because I enjoyed it. I went to school with an undeclared major and ended up learning enough about psychology there to realize how much I loved it. And then I got my master's in clinical social work. In terms of my background in the field, I started off interning in a partial care setting with adults, which is basically a day program with intensive supports like group therapy and case management. We had clients with a variety of different mental health diagnoses like bipolar disorder, schizophrenia, clinical depression. My second placement was in an outpatient facility, so weekly to biweekly counseling. And when I went into the field, I knew that I wanted to continue with outpatient. So I worked in a private practice for a little bit. I then spent a couple of years in community mental health, working exclusively with children and families. And now I work at Tree of Life.
Very nice. And was there something particular as to why you went into the mental health field?
So I was fortunate to have some really helpful experiences receiving my own therapy. As a young person, I really appreciated how my own therapist was able to help me to feel supported and heard. And I remember looking at her one day in a session and feeling like, I want to do what you do. And yeah, I think it also helps that I know what it can be like to struggle with your mental health. I have had obsessive-compulsive disorder myself since I was very young. We're talking around 7 years old. And it may sound a little funny, but I'm really grateful for the experiences that I've had with the disorder. You know, I've overcome a lot of hardships with it, but that has given me the advantage of coming into sessions with my own clients with the ability to have a more comprehensive understanding of the disorder and how it can affect people.
Absolutely. And I was talking about this with someone else. I don't know if it was on one of our last episodes or it was a conversation in person with a therapist, but I feel like it's so much. Now, this could be a personal bias, but I feel like our clients benefit so much more if a therapist has struggled with something like that, because you're coming from like personal experience where it's like, now granted, personal experience is not the same for everyone. What works for one person does not necessarily mean it works for another person. But I think it definitely helps with understanding where the client's coming from. For example, like my therapist, she was like, listen, I understand what you're going through. You're struggling with anxiety. You're struggling with ADHD. Like, I get that. Like, I've had those struggles before too. And it was just very, I don't know, comforting to like know like you understand the struggles that I kind of go through, and I'm not having to like re-explain everything or go out of my way to explain one step further how my brain's working. You kind of already know how my brain's working, which is definitely really nice.
There will be times in my sessions where I'll be able to ask my clients, is your OCD saying this to you, or is your OCD saying that? And they're like, yeah, how did you know? I'm like, just guessing.
Can read your mind.
Yeah.
But don't go anywhere. We'll be right back after this quick sponsored break. Feeling stuck mentally and physically? It may be time to supplement your self-care practices with some holistic healing options. Mind the Body Holistic Wellness in Freehold, New Jersey proudly offers a variety of healing modalities, including Reiki, massage therapy, reflexology, and Himalayan hot stone massages. For more information or to book an appointment, visit www.mindthebodyhw.com. Now back to our show. Okay, and we're back. So just to start, can you explain what OCD is and how it differs from common misperceptions?
I think the most helpful way to conceptualize OCD is to start off by talking about intrusive thoughts, which all of us have regardless of whether or not we have OCD. I'm talking about the thoughts that feel weird or anxiety producing or simply just out of character. That could be a thought about harming someone we love, even though we don't actually want to, or yelling obscenities in a crowded place, or getting sick. As I mentioned, all people have intrusive thoughts like this, although most people, if you ask them, probably aren't going to admit to it. The difference with having OCD is that most people without OCD will experience the thought and go, that was a weird thought, and then be able to move on. But with OCD, that's not going to be possible most of the time. A person is much more likely to become stuck, if you will, obsessing about the thought to the point where they'll find it incredibly difficult or sometimes even impossible to stop worrying about it. So if you're with me so far, you know that we're talking about obsessive, distressing, intrusive thoughts that the individual with OCD cannot stop thinking about. Now, we're going to talk about compulsions, which are what we call behaviors that a person with OCD will do to avoid or get rid of the distressing emotions. It may or may not make sense or can seem extreme or silly. So, for example, a person who's afraid of being contaminated may wash their hands repeatedly for long periods of time. It's excessive, but we can both agree that there is some logic to washing your hands when you're afraid of germs. There's also some logic to checking to see where you put things if you have an obsessive fear of losing belongings. But what's not going to be logical is if you're checking repeatedly, even though you know that you just checked. Something to note is that people with OCD usually have some idea that their compulsions or obsessions are either illogical or somewhat over the top, but will still struggle to disengage from them without treatment. An important thing that I want to bring up about compulsions is that the more a person uses them to avoid or lessen their anxiety, the more likely they are to keep struggling with the obsessive thoughts and the urges to do the compulsions. The nature of the disorder is to make the person who has it feel like their feelings are too big or too uncomfortable to tolerate without compulsions. Avoiding feelings is actually a compulsion as well. Mm-hmm. You know, the tendency to, the second anxiety starts to distract yourself or to want to get away from that feeling. Believe it or not, that's a compulsion.
First, to start off, I didn't know any of that. I feel like coming from someone who has struggled with anxiety and depression, when it comes to OCD, transparently, I don't think I knew enough about it. I knew that there was like this common misconception of you wash your hands multiple times a day, or you turn the light switch on and off a certain number of times. But I'm excited to learn more. I want to know more. I want to know more about it. And I think if you're listening to this and you yourself have struggled with OCD, or you know someone who has struggled with OCD, I think it's going to be a very beneficial episode to listen to and educate yourself on, because I don't think that there's enough resources out there that accurately talk about what OCD is. So that being said, what are some common misconceptions that you may hear from clients or from the public?
So when most people hear OCD, just like you said, they're going to think of a person who's very organized and will become very upset if their things are moved or touched in any way, or a person who is afraid of contamination, things being unsanitary. While these examples do resonate with many people, OCD can present in so many different ways.
And what are the hallmark symptoms of OCD, and how might these symptoms present differently in different individuals?
So there are so many different obsessions and compulsions. They're what we call aggressive obsessions. And that doesn't mean that the person is aggressive, but it means that the thought content, the content of the obsession, obsessions about harming others or harming yourself physically or emotionally, even though you don't want to. Hoarding, saving obsessions, or a person who has a very hard time getting rid of things. This could be something sentimental or something random, like candy wrappers, water bottles, etc. Obsessions about religion or morality, obsessive thoughts of a sexual nature, such as worries about sexual orientation, incest, fears of pedophilia. I'm thinking back on a case example that I learned about years ago. There was not one of my clients, but a woman who was not able to get out of her bed in the morning because she was struggling with obsessive, fearful thoughts about sexually abusing her children. And she was extremely debilitated by these thoughts because they were horrifying to her. She did not want to do this. And that's very, very common for people with OCD, that the obsessions bother them because they are out of character for them. People can have obsessions about their environment, specifically if the environment doesn't look or feel the way that the disorder wants it. That might look like a symmetry obsession where things will need to look or feel the same on both sides. It can also make people feel very uncomfortable if things in their environment are not, if they're not feeling the same on both sides. So if I touch this side with one hand, then I'm going to have to touch the same equivalent. You know, it's not symmetrical, but I think you're picking up what I'm putting down here. If I knock this side of the shelf, then I'm going to have to knock the opposite side. When it comes to compulsions, there are cleaning compulsions, such as washing your hands, bathing repeatedly or for a long time, sanitizing objects, arranging compulsions, where items are being arranged in a specific order, compulsively avoiding certain foods, compulsive praying, feeling the need to do things due to magical thinking, like avoid cracks on a sidewalk, for example. Or avoiding numbers. So if just an illustrative example, if my Facebook post has an odd number of likes, or maybe my OCD likes even, whichever, I will have to do something about it, whether I'm liking it or getting somebody that I know to like it. Otherwise, there's a lot of distress. And I think it's really important to note that you don't actually have to do these things, but it feels very, very intense, like you have to.
Mm-hmm. And are there lesser known symptoms or behaviors that people might not immediately associate with OCD?
Yeah, so one of the most common compulsions I see is reassurance seeking. And that will look like the need for a person to over-explain themselves due to worries about their behavior or how their thoughts might have impacted another human being. I want to say that most, if not all, of the clients I've seen with OCD do this to some extent, to the point where I've developed a pretty good radar for it. If that's something that I'm seeing or hearing a lot in session, then that might be a reason where I'm going to assess for OCD. Another clinician here and I were just talking about how common it is for our clients with OCD to struggle with catastrophizing and all or nothing thoughts. Basically, worst case scenario, or if I'm not the best, I'm the worst. If I'm not going to be a giant success, I'm going to be a giant failure. OCD can make a person feel like things are more of a threat than they realistically are, or like the worst case scenario is the one that's most likely going to happen.
Just like taking that all in, if someone's listening to this right now and they maybe feel like, okay, you're pointing out some things where I think I may resonate with that, what would you recommend for their next steps to be at this point in time?
I would recommend going to see someone who has experienced treating OCD. Exposure and response prevention is currently the most effective treatment, or the most effective known treatment for OCD, basically the gold standard, if you will. And so I recommend finding someone in your area, or telehealth, believe it or not, can be a really great resource, because most of the time, if you're meeting with clients over telehealth and you're doing ERP, it gives you the advantage where you get to basically be with them anywhere. So they can take you to the places, whether it's in their home or another environment where they're having the struggles with the symptoms.
Mm-hmm. And I think that's something really beneficial for our listeners to make sure that they understand. This is just for educational purposes. So if you do feel like you are going through these things, make sure that you seek out an expert. There are lots of experts out there who are experienced with OCD and experienced with exposure therapy. So make sure that you are educating yourself, not just listening to this episode. Podcasts are great. But with specifically OCD, you have to make sure that you're working one-on-one with someone in order to change these things. And sometimes medication may also help us a lot, depending on what you're going through, depending on how impulsive your compulsions are. all these things, really do matter. There are also different types of OCD. So there's OCD and there's also obsessive-compulsive personality disorder. Could you just tell us a little bit about the distinction and why that's important? Just because I think some people may get confused between OCD and OCPD.
Absolutely. That's a great question. So OCPD is less about intrusive, fearful thoughts or performing compulsions to avoid or reduce distressing feelings, and more about perfectionism or having things done a very specific way. Things like group projects may be difficult for the person with OCPD because it will often feel for them like their way of doing things is the right way of doing them. This can lead the person with OCPD to struggle with wanting to control the things around them because of the feelings they're experiencing. OCD can also include perfectionism, but it's going to be more about intrusive obsessive thoughts and the distress that they cause versus that need for the perfectionism or having things done a certain way. Think what if thoughts, what if this happens, what if that happens, or like I mentioned before, catastrophizing thoughts. Mm-hmm. When a person has OCPD, they can also show signs of OCD. However, you can have OCPD without having the intrusive obsessive thoughts.
I feel like that's really interesting. It's definitely a whole other understanding of like what OCD is, and just to hear like the difference between specifically OCD and OCPD, I think can help distinguish for someone listening, okay, like maybe this one resonates with me more than the other.
But I think a really relevant point to make is that there are a lot of people with OCD who unfortunately haven't received proper diagnosis or treatment for their symptoms. There's a really great psychologist who specializes in OCD named Jonathan Grayson. He wrote this book entitled Freedom from Obsessive-Compulsive Disorder. By the way, I highly recommend checking it out if you think that you or a loved one might be struggling. But anyway, he talks about how OCD will commonly start during a vulnerable or stressful time in a person's life, either during childhood or early adulthood. And then what usually happens is that the person will experience distressing obsessive thoughts about whatever their OCD has happened to grab a hold on, and inadvertently find themselves getting caught up in a repetitive cycle of doing compulsions to make themselves feel better. What ends up happening is that the compulsions get reinforced because in the moment they are helping to alleviate distressing feelings. So helpful in the short term, but in the long term, all they're really doing are exacerbating the disorder. Sometimes my clients will tell me that they feel silly for doing compulsions, and I'll have to explain to them, listen, it's not silly. It actually makes sense that you're doing these compulsions because compulsions will work to reduce the anxiety, like I said, in the short term. But again, they only work temporarily and are going to usually result in the person having to do them on a more frequent basis. There are people with untreated OCD who cannot get to work on time because they can't stop checking the locks on their doors due to an obsessive fear. That can often be a harm obsession, also known as the aggressive obsession. Another example would be a person who has to rearrange or feels like they have to rearrange objects until they feel just right. We actually call that just right OCD. Or a person who struggles to focus on anything other than the obsessive worry about the possibility of hurting another person's feelings until they have obtained reassurance for this person. By the way, I think I mentioned to you before, there are so many different types of obsessions and compulsions. A great thing to check out is the Y box. It stands for Yale Brown Obsessive Compulsive Scale, YBOCS. That they didn't include every single possible OCD presentation under the sun, because that would be impossible. You can have OCD about so many different things, but they do give a really good overview of different kinds of obsessions and compulsions.
Mm-hmm. And I think that's something definitely to take note, that there is not like OCD and OCPD is not a one size fit all. You have to definitely get evaluated for this disorder and this diagnosis, and you have to make sure that you are getting the type of care that you specifically need. But we will be right back after this short break. This episode is brought to you by Thomas Sweet Ice Cream and Chocolate. Thomas Sweet is a locally owned business with over 45 years of experience serving custom ice cream creations and delectable chocolates. They are known for their blend-in ice creams, where there are endless options to create your own ice cream treat with customizable topping mix-ins. Stop into the Thomas Sweet Ice Cream Shop located at 183 Nassau Street, Princeton, New Jersey, or contact them at 609-683-8720 or reach them at www.thomassweet.com. Now back to our episode. Okay, and we are back. So how is OCD typically diagnosed, and what should someone expect if they are seeking professional help? So I know we briefly kind of touched on it, but we could kind of go over like how does someone even, or how does a professional even assess how OCD is diagnosed?
The Yale-Brown Obsessive-Compulsive Scale, as I had mentioned, is an assessment that clinicians will administer as a clinical interview. It is not intended to be diagnostic in nature, but it is a great way to help clients to identify their experiences with the disorder because of the examples provided on it. It will list a symptom followed by a description of what that could look like. And it's common for therapists to start with an assessment like this. I know I do. There is also a child version, by the way, called the SciBox. So the Y box and the SciBox, Yale-Brown Obsessive-Compulsive Scale, child Yale-Brown Obsessive-Compulsive Scale. You can also expect your therapist to use the DSM-5, which is the big old book that we mental health professionals use for diagnostic purposes.
So based off of them being diagnosed, what is the most effective treatment option available for OCD today?
So something that I learned when I was trained in ERP, exposure and response prevention, that ERP is actually a form of cognitive behavioral therapy.
Mm-hmm.
So it consists of working with your therapist to identify the obsessions and compulsions that are causing the most distress in your life. Your therapist will collaborate with you to build what they call a SUDS hierarchy, which is a list of different exposures to help you gain practice facing what your OCD has caused you to feel like you need to avoid, which is typically going to be due to anxiety. There are what we call in vivo exposures, which are exposures that we do with real life situations, typically in person, and imaginal exposures, which we will facilitate with a recording or a video. The way that I was trained and therefore explain it to my clients is that I, as the therapist, am their GPS. It is my job to teach them a rating scale to assist them with communicating the intensity of their distress. We will gradually work together to help them to reduce the hold that the OCD has on them in their life. For most people, practicing exposure to anxiety triggers on a repetitive basis will result in a reduction of anxiety over time, which we call habituation. You think of the root word of habituation, it's habit. As it becomes a habit to expose yourself to the things you're afraid of, usually anxiety is going to go down. That isn't the case for everyone, but a person can still improve their ability to tolerate uncomfortable feelings, even if they're not habituating. So even if the anxiety is not reducing, it doesn't mean that there's just no hope and that they're not going to get any type of improvement from treatment, because the brain can learn, hey, I've been feeling this anxious, I've been doing these exposures, and it's all right. I've been doing it. And even though I feel this way, I've been able to do these things over and over again. So just because I feel this anxious doesn't mean that I'm not capable of facing my fears. I will also incorporate a really amazing therapy along with ERP. I honestly can't imagine doing ERP without it, because I'll be real, it's a challenging therapy because you're asking people to face fears that they're afraid of, and that, it's not their fault they're afraid of it, it's the disorder. ACT therapy, acceptance and commitment therapy, consists of finding creative strategies to help clients with the disorder, essentially separating it from their own self, which is an essential part of OCD management. Psychotropic med management is also a helpful part, or can be for many people. It can be a helpful part of OCD treatment, but I would never recommend it for a replacement for therapy. However, it can work to help the treatment to be more effective. Prescriber coordination of care, working with my client psychiatrist, is very important to me as a clinician.
Well, and I think that's something amazing that we offer, that we have our prescribers here, is because it's very easy for our nurse practitioners and for our clinicians to have that coordination of care. And it tremendously helps the client just overall succeed when every single person part of their team are collaborating together for the overall well-being of the client. And that's not just with OCD, that's with all different types of disorders. If you are seeing a prescriber, it is definitely recommended. If you are seeing a therapist, that they work together and they kind of collaborate on your care. Like you said, it's not a one size fit all. It really just depends on the specific individual, but them working together can definitely show a lot of results. We stated that medication management as well as therapy both can improve the client's overall well-being and overall quality of life if they do get, or if they are diagnosed with OCD. So would you be able to share any success stories or any examples, of course, without breaking confidentiality, of clients who've made significant progress in their day-to-day life?
So I am forever impressed by my clients and the strength that they are able to find within themselves in treatment. I have literally seen people go from having extreme distress about an exposure to getting to a place where I'm hearing them say, oh, that exposure, I've got that down. That's not a big deal anymore. Or, oh, my OCD still tries to bother me like it used to, but it's no match for me anymore. I have had the privilege of watching people who weren't even sure that they could get better to begin to reclaim their lives from the disorder.
I think that is like phenomenal. I feel like to even have a client say that, like them coming to you with this type of exposure, whatever it may be, saying, I have this fear. And it's one thing to like have a reoccurring thought and just be like, okay, and, you know, avoid it and avoid even thinking about it. But for you to, I guess, admit that you have that fear to not only like to yourself and then to take that next step to call a facility and actually set up that appointment and to then go to therapy and actually talk about that fear with a professional is huge. So you already did the hard part of making that first step. Now you're working through everything else. And for you to get to a point where you're looking back and it's like, oh my gosh, it's probably a really rewarding feeling for you as well. I'm sure that the clients feel great recognizing that. But I was listening to a TikTok a couple of days ago, or I saw like a video a couple days ago, and the person said something like, sometimes people can feel very discouraged with whatever's happening in their day-to-day life now. But if you think about it, would you trade places with yourself, with your old self a year ago? And if you wouldn't, then you have made progress. Things may not be amazing, or maybe you took one step today and took 4 steps back yesterday, but that you're still making progress. So to recognize that, long story short, I'm sure is very rewarding on the client's perspective. And then for you to like see them and see that whole progression, it's cool. It's cool. And I think it's an interesting process that I think a lot of us are, some people are unfortunate to not have this type of care. But if you are able to get, you know, mental health care, there's things that you can do and advocate for yourself. But we will be right back after this sponsored break. Today's episode is brought to you by Tree of Life Counseling Center, where people come to heal, deal, and learn to thrive. They currently have immediate availability for talk therapy and medication management with a team of over 50 licensed clinicians. Are you feeling alone? We all can use someone to talk to. Call 732-393-8391 or visit us at www.treeoflifecc.org to start your journey of self-discovery and healing today. All right, and we're back. So what are some practical strategies for managing OCD on a day-to-day basis? Now, I know we mentioned OCD for one person can look very different from another person, but are there like some baseline things that anyone diagnosed with OCD could benefit from?
Yeah, so you want to really focus on feeling your feelings. A common compulsion, which a lot of people don't know, is the urge to tense or clench up your muscles. That might look like your jaw, your chest, your hands when you are stressed, scared, or having uncomfortable feelings and thoughts. You want to unclench your muscles as best you can and prioritize calm, regular breath. I'll tell my clients, you don't actually have to be calm, but you want your breath to be calm, and you want calm body, calm breath as best as you can. Acceptance and commitment therapy strategies, also known as ACT, as I mentioned, can help with improving the ability to tolerate the distress that OCD brings. I'm a really big fan of naming the disorder. calling it something after a character that you think is funny or weird. When it pops up, referring to it like, yeah, okay, Winston, all right, I see you. These are act strategies that we use to call out the disorder and its efforts to make a person feel like they're not capable of feeling their uncomfortable feelings. My clients will tell you that I often talk about OCD like it's a person because it behaves like one. A lot of times it behaves like a bully. OCD will often actively try to come up with new or intensified obsessive thoughts once it gets the sense that a person is working to get better. So you want to be like, nah, I see you. I got your number. I'm a really big fan of a strategy that was introduced by a really well-known OCD psychologist. His name's Dr. Reed Wilson, and it's called the 6-minute game. And I want to clarify, it doesn't really have to be 6 minutes. We could even call it the 6-step game if we wanted to. It's really just a way to conceptualize what to do. So the first 3 minutes of the game, or that's, we're going to assume it's been 3 minutes. He says that it's none of your business what happens in the first 3 minutes. It's really the OCD's business because within 3 minutes, it's just the OCD trying to insert itself into whatever situation the person is in. It can be especially common for OCD to bother us in response to similar stressors or in environments where it has previously caused the distress. So basically the brain will recognize, oh, I've seen this before, and OCD will pop up. Although that doesn't have to be the case, OCD can just pop up anywhere. And so by the time a person realizes that they're having an obsessive intrusive thought, it's probably been more or less 3 minutes. What the person with OCD needs to think about is minute 4. Here's the part where you want to focus on what Dr. Wilson calls stepping back from the OCD. It's the part where you essentially call it out. You say something like, that's my OCD, or that's an obsession, or I'm having an obsessive thought, or Mark is here, assuming Mark is what you've decided to call your OCD. It doesn't matter what you're saying or calling it. The point is that you're making a statement to recognize that your OCD has been activated and is separate from you. The reason that he does that is because there's research to support that with time, when you're having these distressing obsessive thoughts, labeling them as your OCD will cause your brain or can cause your brain to learn, okay, this feels like a threat, but this is the disorder. At 5 is where he calls it turning your back. So we've already stepped back, metaphorically speaking. Now we want to metaphorically turn our back. You want to say or think something internally to let your OCD know that you are not the one right now. You can even say that to your OCD. Nope, not having it, OCD. Nope, I see you. I know you're there, but we're not going down this road. You can make the noise that you're making. You don't have to go away. I'm feeling my feelings, but you're not the boss in this situation. Minute 6, this is where Dr. Wilson talks about elevating an activity of importance. So this is going to look different depending on each person and what their values are. I encourage my clients to think about what is important to them. What would I be doing right now if my OCD weren't bothering me? Would I be doing my homework? Would I be texting a friend? Would I be on the phone with my mom? The key is to practice noticing that the OCD is there without avoiding the uncomfortable feelings it's bringing up, as it's actually the avoidance of feelings, as I mentioned earlier, that maintains the disorder. And finally, OCD being the repetitive disorder that it is or can be, it's not unusual for it to come back after we finish the game. So OCD might try again because it's a persistent disorder. And so when that happens, we consider that a new 6-minute game.
So anytime there's a new compulsive thought, you would play this 6-minute game or 6-step game.
Yeah.
Very interesting. And I like that if you are thinking that maybe you have OCD. Now, again, we're not going to be self-diagnosing ourselves. We're going to get diagnosed by a medical professional. But this is something that if you are waiting to hear back from a, counseling office, if you're waiting for your appointment to come because it's next week, try this game out. It's 6 minutes. See if it works for you. See if anything happens to your thought, and then talk about that with your therapist when you have your session and say, listen, this is what I am thinking. This is how my brain's working. I tried this. And who knows, maybe there's different levels of OCD. There's different extremes. So you have to, again, see what is going to best fit for you and what will help you get the most progress with you in enhancing your life on the day to day. Now, let's say, me personally, I don't have OCD, but a family member of mine does have OCD. Um, what would you recommend me do in terms of being there for my family member and how to best support someone? What advice would you give?
It's important to find the balance between having patience for your loved one and empowering them to remember that they are strong enough to push back against their OCD. It's very common for well-meaning family members to provide what we call accommodations to make life easier for their loved one with OCD. In most cases, with other disorders, accommodations are a good thing. When it comes to OCD, that is not the case. An example of an accommodation would be reassuring your loved one that they are safe and that the worries they're having are not going to come true. Or doing laundry every day for your loved one because that's what the OCD is telling them needs to be done. Another example is buying things to help a person complete their compulsions. Instead of accommodating, we want to believe in our loved ones and encourage them to face their fears as best as they can. With that being said, we also want to be careful about pushing our loved ones to do things that they are not willing or ready to do. It's important for people to understand that it's not going to work if the person with OCD is being forced to make changes. Working with a therapist who understands OCD and how to treat it and encouraging your loved one to do the same is really going to be your best bet. Something that I will sometimes say to my clients, if they are feeling very distressed regarding an exposure, we're talking high distress, I will remind them, look, this has to be up to you. This is your choice, what we're going to do today. You may not be able to do it 100% today as though you did not have OCD. Maybe that is what we're working on most of the time. However, what can you do? Because you may not be able to do everything to push back against your OCD today, but you can do something. And so if you cannot open the door because you have a contamination obsession, can you stand next to the door? Or if that's too much, can you imagine opening the door? Can you grab the door with a tissue? What are you able to do in this moment? I will also tell my clients, I'm not going to push you to do things that you're not ready to do. If I am hearing the disorder get in the way where my client needs to remember everything that they've overcome already in terms of working on their OCD, I'm here for that. I'm all about encouraging them to challenge themselves. But I'll remind them, listen, if I'm telling you have to do an exposure, hey, I'm not going to do that. I'm not that type of therapist. And even if I were, it wouldn't help you anyway. There's no point in doing that.
So one thing to note from that is if you are going to therapy for specifically OCD, if you do feel pressured that your therapist maybe is saying, listen, we're going to try this exposure therapy. There's nothing wrong with advocating for yourself and saying, listen, I don't know if I really feel comfortable with that, but maybe we can try this. Or I don't know if I'm really feeling up for that today. Is there something else that we can kind of do to maybe come up with a plan that can help me when my OCD is triggering me in that moment? So that being said, if you are a loved one who is supporting someone in your family who does have OCD, it doesn't hurt for you to go to therapy to see how you can best assist your loved one. It's very different with just the person who's diagnosed with OCD to get treatment, and very different with a family member getting treatment. And the treatment for the family member is just you learning tools and you learning ways to best support them, and also talking about how their OCD could be affecting you too. How do you guys intertwine? What is that dynamic like? Is it a partnership? Is it, a parent-child dynamic? All of those things are things to kind of think about and see how it's affecting your day-to-day. But that being said, if someone isn't available to get counseling for themselves and their loved one is struggling with OCD, are there any resources or support groups that you would recommend where they're able to at least do something to help their family member?
The International OCD Foundation, IOCDF.org, is a really great resource. They have some wonderful educational resources from conferences to literature to podcasts. They share information to link people with support groups for both the people who have OCD as well as their families.
And we'll be sure to leave that website down below, just so if anyone that's listening to this episode wants to access that resource, they are able to do so. So changing gears a little bit, why do you think that OCD is so frequently misunderstood?
I think a big part of it is that a lot of people assume that OCD is about what they've seen in the media. I'm talking about the stereotypical OCD presentation, compulsive cleaning, organizing, more focus on the compulsions versus the internal feelings that's causing the engagement in the compulsions. And I get that to a point because the compulsions can be more visible. There are many people with OCD who won't talk about their intrusive thoughts because they feel ashamed. The disorder can also sometimes create intrusive, obsessive, fearful thoughts about sharing the disorder with others. An example might be the OCD saying to the person, something horrible is going to happen to your loved ones if you share. And that can be a really big deterrent.
And what are some steps that you think society should take to break down the stigma surrounding OCD?
I think adapting an attitude of curiosity is key. It's a lot easier to form a snap judgment about what you think OCD is, or even what any disorder is, than it is to take the time to learn to ask questions, listen to podcasts, read articles on IOCDF. Oh, and please stop saying, I'm so OCD.
It's not, it's very offensive, I think, especially for people who do have OCD. It's like, what does that mean?
It's not an adjective, it's a disorder. And I think a lot of times people say it and they mean it in a funny way. They're not meaning to say or do anything harmful, but it can be inadvertently dismissive of what people with OCD are struggling with and going through.
Mm-hmm. And so speaking of society and just the stigma surrounding OCD, clearly the media doesn't necessarily portray OCD in the best light. So how would you recommend the media improve in portraying mental health conditions like OCD more accurately?
I think that including an OCD specialist on the writing team would be a great start. And by the way, Tree of Life and I are available. Just kidding. No, but in all seriousness, I do think that having a mental health professional with a background in OCD is ideal. And if that's not in the budget, I would say reading Freedom from Obsessive-Compulsive Disorder by Jonathan Grayson, as I mentioned, getting permission to participate in the support forums for families on OCDF so that you're getting a more comprehensive sense of what OCD is actually about.
I love that you said that, because I think if you're listening to this episode, if you've seen Inside Out or Inside Out 2, I think part of the reason why that movie did so well with depicting what anxiety is because they had mental health professionals on the writing team actually talking about what these different emotions and feelings are like. And anxiety is just one of them. I mean, apparently they're coming out with another episode. So maybe, Riley will have some OCD aspects. We don't know. We don't know what emotions will come up. But that being said, I think even just the movie Inside Out 2 did such a good job at portraying what anxiety really is because they did have mental health professionals on the writing team. So I think that's a really great recommendation. And if you're listening to this and you are a film producer and you're thinking about having OCD in your film, you could call Alyssa, you could call Tree of Life. We're happy to give you advice on how to accurately depict OCD, just because there is this conception that we are just trying to break the stigma on. So that being said, though, we will be right back. We're going to take one more sponsored break.
This episode is brought to you by Confections of a Rockstar Bake Shop and Catering. Are you looking for a sweet treat or custom cake and desserts for your next event? Stop into their Asbury Park location where everything is made from scratch using high-quality ingredients. Custom orders can be placed online at www.confectionsofarockstar.com or by calling 732-455-3510 today.
Okay, So we are just getting to the end of our episode. So Alyssa, what are your parting words for someone who may be struggling with OCD?
Please know that if you are struggling with OCD, that things can improve with treatment. The disorder isn't something that can be cured. If you've got OCD, you're going to have it for life, but it can be managed with the proper tools and supports. And I can tell you from both personal and professional experience that the difference can be like night and day. It's the nature of the disorder to not want you to get help. Please remember that you are the boss, even if it doesn't feel like it right now. Successful treatment can help you to get to a place where you believe that.
So that being said, if you are struggling with OCD, if you think you are struggling with OCD, do not be afraid to advocate for yourself. There is support. There is ways to have your day-to-day life be easier for you, where you feel more fulfilled, where you feel happy, and you don't need to be struggling with the things that you are struggling with. And there are support and treatment out there for you. So Alyssa, we just wanted to say thank you so much for coming on this episode. We hope that if you are listening, you did learn something new. And if you know someone that is struggling with OCD, feel free to share this episode with them. And I'm sure we will see you, Alyssa, on another episode.
That'd be great. Thanks for having me.
Thank you. Bye.